Hello, everyone, and welcome to Navigating Lung Transplant Challenges, Current Research, Clinical, and Community Perspectives. My name is Dr. Alexander Graham, and I'm a transplant pulmonologist and the Assistant Director of the Adult Cystic Fibrosis Program at Duke University. I'll be moderating this session today, and we'll be introducing our other speakers in just a moment. Before I do, I want to provide a few logistics and reminders. This session is being recorded and will be available after the event on the CF Foundation YouTube channel. You'll be notified by email when session recordings are available. We will be taking questions from the audience throughout the session and will answer them during the last 20 minutes of the session. We encourage you to submit your questions at any time into the chat box. We will not be able to answer questions about individual care and treatment plans, and we encourage you to use the information you learned today to have conversations with your care team. We may not be able to get to all the questions, but we will do our best to answer as many as possible. Before we begin, I want to remind everyone of our event conduct guidelines available on the Foundation's website. Please be considerate, open-minded, and respectful. We ask that you do not use malicious or offensive speech and do not ask for or give medical advice. If at any time you feel the event conduct guidelines are not being followed, please contact a CF Foundation staff member at the help desk. Finally, if you experience any technology problems during the session, please visit the help desk in the expo area on the left-hand side of your screen. Now let's get started. We have a quick poll to get an idea of who all is joining us today. The poll can be found on the right side of your screen next to the Q&A and chat. While you're filling out the poll, I want to take a moment to introduce our other speakers. So I'm going to leave it up to our other speakers to introduce themselves, starting with Grant.
Hi, everyone. My name is Dr. Grant Turner. I'm a cystic fibrosis and lung transplant pulmonologist at the University of California, Los Angeles, and the Associate Medical Director of our Cystic Fibrosis Center. Excited to be speaking today.
Hi, I'm Elle. I am 43 years old and I do have CF and I am a post-lung transplant patient. I was transplanted in 2007 and post-kidney transplant 2011, and I currently reside in Miami, Florida. I'm excited to be here with all of you.
Great. Thanks for the introductions, guys. So we'll take this opportunity to look over our poll responses. All right. Oh, just waiting for that to come back up on the screen. So it looks like so far we have an even mix between different people coming from different avenues here. So we have about a quarter of people answering are a lung transplant recipient. Welcome. We have about a quarter of people are caregivers or family members of a lung transplant recipient, healthcare professional involved in a lung transplant, and then no direct, almost a little bit more, about 36% have no direct connection but are interested in learning about lung transplant. So thank you for answering this poll. I'm hopeful that all of you will get something out of today's talk, and we're really excited to be able to provide this information to you today. So why don't we get started with our presentation? So first off, I just want to make sure that there are no disclosures aside from what's listed on here between myself and Dr. Turner. So first off, I wanted to take a moment to discuss why we are discussing lung transplant and cystic fibrosis in the first place. As you may know, cystic fibrosis is a disease that can affect multiple different organ systems, leading to a wide variety of symptoms leading to manifestations such as sinusitis, pancreatic insufficiency, malabsorption, diabetes, and in most cases, lung disease. The natural progression of cystic fibrosis is usually defined by the progression towards advanced lung disease. Before highly effective modular therapy, up to 90% of patients with cystic fibrosis were dying due to end-stage lung disease. Lung transplantation has historically been a treatment that has not only improved the life expectancy for people with cystic fibrosis, but also their quality of life. This is a graph, this is a graph from the International Society of Heart and Lung Transplantation's Transplant Registry. What I wanted to convey here was that over the last few decades, the number of lung transplants that are being performed worldwide has dramatically risen. Within the time period between January 1995 and June 2018, there were 63,530 people who underwent lung transplantation reported in this registry. About 15% of these people were transplanted for cystic fibrosis, which was the third most common reason for transplant, making up just over 15%, as I said. When focusing only on double lung transplants, 43,572 people were transplanted during this time period. And cystic fibrosis was the second most common reason, just under 22%. Finally, this is a graph that compares survival curves after lung transplantation. The purple curve at the top is the curve for people with cystic fibrosis, which corresponds to a median survival of almost 10 years after transplant. What this means is that at around the 10-year mark, half of the people with cystic fibrosis who have had a lung transplant will be alive, while the other half will have either passed away or their transplanted lungs are no longer functioning well. This is much longer than for people transplanted for other lung diseases, which as a whole have a median survival of about 5 to 6 years. So overall, discussing lung transplant and cystic fibrosis is important, as there are many people with cystic fibrosis who have had a lung transplant who are living longer lives. Despite modulator therapy being available, there are still many people with cystic fibrosis who either do not qualify for modulators or do not have a significant benefit when using them who will end up needing a lung transplant. So understanding the long-term complications, treatments, and possible future research is important. One of the biggest challenges after lung transplant is rejection. The immune system is amazing at finding and fighting things from outside the body. This helps us stay safe from bacteria, fungi, viruses, and other foreign materials we are exposed to. However, in transplant, we focus on trying to suppress the immune system so it doesn't recognize the transplanted lungs and start attacking. Unfortunately, despite our best efforts with immune system suppressing medicines, this unfortunately still happens, is what we call acute rejection. Acute rejection can either be from immune cells directly attacking the lungs, or it can be from immune cells that make antibodies which target the lungs to be attacked. When acute rejection happens, we give medicines that suppress the immune system to stop the rejection process and hopefully reverse some of the injury. So if there is acute rejection, what is chronic lung allograft dysfunction, also known as CLAD, which you may have heard about? Well, CLAD is what we are referring to when we talk about chronic rejection. It is an umbrella term, and it describes when the lung function decreases for no particular reason that we can pinpoint. Importantly, it is not just a loss of lung function, but also a persistent loss of lung function that happens in CLAD. So what causes CLAD? We really fully don't understand how CLAD happens. We just have more of an understanding of pieces that may be associated with it. We know it is more likely to happen after situations where the immune system is activated, so such as after fighting a viral infection, after fighting a bacterial infection or a fungal infection, or after an acute rejection event when the immune system is ramped up. When CLAD is developed, there's often scarring of some of the very small airways or of the tissue surrounding the lung. And those are pathology or findings we can see that it's associated with it, but as I said, we don't quite understand exactly why it happens. Unlike acute rejection, we do not have any great therapies to reverse CLAD. So I want to take this opportunity to pass it over to Elle so she can talk a little bit about her transplant journey and how this all relates.
As I mentioned earlier, I was at 17% lung function when I got transplanted in July 2007. And then the medications caused me to have kidney failure shortly after. So around March of 2011, I received a kidney from my husband. However, prior to the kidney failure and right after my lung transplant, I was extremely healthy. My surgery had no complications, and I was in the hospital recovery time for about 2 weeks. And I was back on my feet the minute I got out of the hospital. I also want to share that my lung function was great. It was up around in the 90s compared to the 17% that I had prior to transplant. And also, excuse me, I was living a very active lifestyle. I was going to school full time, I was working full time, and I was actually training for a 5K full time until about one time that a couple of days before my 5K that my O2 dropped to about 87%, and I had to go to the ER for shortness of breath. It was then determined after further testing and PFT trends and things like that, it was determined that I was unfortunately in chronic lung rejection. But speaking of CLAD, Dr. Grant, how do we differentiate between CLAD and an infection? Because originally for me, I thought I just had an infection, but it ended up being that no, it was chronic rejection. So how is one able to tell the difference?
It's a really great question. Thank you, Elle, and thank you, Dr. Graham, for introducing chronic rejection. And we'll talk a little bit more about distinguishing from infection and rejection a little bit later on. First, I want to unpack the label a little bit of chronic rejection. And I'm so appreciative, again, Al, for you giving us a little bit of your personal experience. I know based on the initial survey, we have some individuals here who may have already had a lung transplant or may need one in the future. And so for many, the discussion of CLAD or the diagnosis of chronic rejection is really scary. I know when I'm having that initial discussion where we are talking all about lung transplant with an individual who's considering it, the idea that chronic rejection is the number one cause of death after the first year is terrifying. Thinking that you just went through this exhausting, physically exhausting, emotionally exhausting, financially exhausting year of lung transplant, and then potentially having your life shortened is a huge mental toll to take. And so, for the next part of our discussion, I'd also like to unpack this label a little bit. First, people may be hearing words such as CLAD, chronic rejection, RAS, BOSS, and rejection sort of thrown around interchangeably. And we won't go into all of the specifics of each of them, but all of them together are same as saying CLAD or chronic lung allograft dysfunction, where the body has recognized the lung as foreign and is starting to cause some damage to it in a progressive way. When we say these terms, a lot of individuals will report that they are hearing or thinking, I have 6 months to live. I'm worried about that one time I missed a dose of my immunosuppression. How did this happen? Did I make a mistake in deciding to have a lung transplant, or did I make a mistake afterwards? And often people want ask, what did I do wrong? And so I hope by discussing this today, we can shed light on how this diagnosis can cause some problems, why it happens, which Dr. Graham already mentioned a little bit of, how people describe their life after a diagnosis of chronic rejection, and the issue with chronic rejection treatments. So, as defined by the International Heart and Lung Transplant Society, chronic rejection is when you reach 80% of your personal best pulmonary function tests after a lung transplant. So, for the majority of people with CF or healthcare providers, you know that almost every visit with someone who has cystic fibrosis or after a lung transplant, we're going to do a pulmonary function test, a breathing test, and that will give us an idea of how your lungs compare to people who are the same age, the same height, and the same sex assigned at birth as you. And they pre-transplant are the way we decide who should be referred for a transplant evaluation and maybe be listed. And afterwards, they're how we track the health of the lung or lungs that you received. So your personal best is your two best PFTs at least 3 weeks apart. Chronic rejection then comes in when you're at 80% of your best. And so you can see from the graph on the left that this person reached 100% of, again, the expected based on their age, height, and sex assigned at birth. And they had an incredible response to lung transplant and are going to feel great. And reaching 80% of that baseline, if you can see, let's say 3 years is where that blue line is, they're at 78% of their expected FEV1. They may still feel totally normal at 78%, and it was only identified because we were doing pulmonary function testing. This level of lung function should not be limiting. They, again, may not notice it. And if it stabilizes at that level, then they could have years of exactly normal life afterwards. In comparison, the person on the right, as an example, only reached 40 to 50% of their personal best. And by reaching 80% of that 40 to 50%, they may not have felt as well as the person who reached 100%. But again, they're not going to notice a big change when they reach just the 80% because it is a minimal drop from their baseline and will not necessarily be reflected in their day-to-day lifestyle. The next problem with chronic rejection is it still chronic rejection at certain points? So definite chronic rejection by the diagnosis criteria is having that less than 80% decline for more than 3 months. But you can see in this individual on the left that they had a definite decline. They reached the 3 month mark, but then by the next time they visited their doctor, they were already back above it. So is this still chronic rejection, or was there something that we weren't able to identify and got better with no intervention from the doctors? That is compared to the person on the right, where their pulmonary function tests continue to slowly decline over time. Then the next question that many people ask us is, when will chronic rejection happen? And for how long will I be in chronic rejection after I get that diagnosis? Is this a death sentence? Do I need to be, filling out my will that I have 3 months? Is this something that I have 20 years afterwards? And they have looked backwards at the data to try to help us answer that question. This data is extrapolated from the overall database of everyone who had a lung transplant between 1994 and 2011, so a tiny bit old. But you can look at the graph on the left, and it shows you the percentage of individuals who had had a lung transplant and were free of rejection, BOS being a form of chronic rejection. And around 50% were free of chronic rejection at 6 years. 25% were completely without chronic rejection at 10 years. For the purposes of this talk, ignore the two colors, scenario one and scenario two. In that same study, then, after they had a diagnosis of chronic rejection, or again, BOS, you can see that they survived on average 4 years if they had a bilateral, both sides transplanted. And so, unfortunately, this means some people may pass away early on after the diagnosis of chronic rejection, but the majority of people are going to have a significant amount of time with which to make sure there's no other cause for the chronic rejection, consider clinical trials, which we'll discuss more later, or other available therapies. Once the diagnosis of chronic rejection is made, many of my patients worry what their life is going to be like. What we know anecdotally and from the literature is that chronic rejection quality of life for people who have chronic rejection is different than what they may expect, and thankfully in a positive way. This can be different for every individual, but I think it's helpful to review what has been described. A very interesting study out of the University of Toronto back in 2018 looked at individuals' expectations about their healthcare quality of life after a lung transplant, but they asked them before the transplant had happened. So they said, after you've had your lung transplant, how do you think your quality of life will be immediately after? How will it be after you have been diagnosed with chronic rejection? And how will it be in the various stages of chronic rejection? And interestingly, overall, you can see that their quality of life expectations pre-transplant versus when they were actually in the phase that they had asked them about was much higher than expected for both scenarios that they looked at, a way to measure expectations, that it was higher than expected if you had asked them before transplant. This was true as well if you looked at CLAD stage 1 and CLAD stage 2 for all disease that need lung transplant. So whether they had had cystic fibrosis as a reason that they needed a lung transplant, pulmonary hypertension, interstitial lung disease, in all of them for CLAD stage 1 or CLAD stage 2, which is based on how severe the lung disease is, their expectations or their quality of life were higher then their actual quality of life was higher than what they had expected it would be if you had asked them before transplant. Another viewpoint from a single center in Germany reviewed the overall ability or disability of individuals living with chronic rejection after their diagnosis. And in this study, they looked at individuals from a 10-year period up to 2020 who had developed chronic rejection and asked them standardized questions regarding mobility, the ability to take care of themselves, do their usual activities, feeling pain or discomfort, and anxiety or depression. And they found, as expected, that as someone moved through the stages of chronic rejection, they would have more disability overall in those five key categories. But in stage one, it was around 10 to 20% of people who had any findings there. And by stage four, it was only 50%. So 50% of people still felt very able despite the decreases in their lung function. Why then, if chronic rejection can be so disabling for some and happens to the majority, if not all of our recipients, do we not have lots of research and treatments for it? Unfortunately, studying chronic rejection is very difficult for a variety of reasons. First, as we demonstrated on my rudimentary PFT graphs, you can see that people come in and out of chronic rejection, and determining if something is definitively just from chronic rejection can be difficult for a specific individual. In line with this, our definition as clinicians, as societies for chronic rejection is a bit simplistic, that we're just looking at pulmonary function testing. And there are opportunities for us as a society to look at blood testing, to look at testing from bronchoscopies, to look at x-rays and CT scans to determine if damage is occurring that PFTs are unable to capture, or to also look at different treatment endpoints. Next, as Dr. Graham mentioned, we have a poor understanding of why chronic rejection happens and may happen for a lot of different reasons for different people. And so applying a one size fits all treatment for chronic rejection can be very difficult. Alongside that, every transplant center will use medications a little bit differently than the other. And so immunosuppression given at the time of transplant over the course of years may be different. And they may also have different answers for, is this an infection, like Elle mentioned, or is this rejection? And these mixed responses alongside individuals having a mixed response to treatments means that chronic rejection is even more difficult to understand. And finally, research into chronic lung allograft dysfunction is expensive. There are not very many patients that undergo lung transplant in a year compared to other research that is done. It's difficult to determine if you're in chronic rejection, and the benefit to society can be lower than in other drugs that pharmaceutical companies may want to research. And so they may prioritize other research, even though we find this to be one of the most important things that should be researched. With all that being said, Elle, can you give us a little bit about your journey after your diagnosis and if you were able to go through the clinical trial?
Yes, definitely. So once I was diagnosed, as I mentioned, I had my lung transplant in 2007, and in April of 2015 was when I was diagnosed with actually BOS. It was definitely a scary conversation to have because, like most patients, I thought, "Oh my gosh, I'm in chronic rejection. This is the worst of the worst, and how much longer do I have to live?" I just started living again. Um, my lung function also had declined about 40%, but I was treated right away. It was caught very early, and I was treated right away in the hospital for 5 days with high dosages of IV Solimedrol, which is a type of steroid. And I was sent home on a treatment regimen where I now take Azithromycin 3 times a week and Symbicort inhaler. I don't need to do aerosols. However, I feel that they are helpful for me when I'm going to work out. So I like to do an aerosol treatment of albuterol right before my workouts, and then I do my Symbicort inhaler, which that's been my regimen since 2015, and here we are 10 years later, and I'm still going strong. At the time, however, I was not given any information on treatment options or trials, other treatment options in the sense of because my center does not do some of the other treatments that other centers do, like photophoresis. My center at the time here in Miami was not doing that, and they're still not doing that. So for me, it was not an option, and they did not know of any trials at the time that were out there for chronic rejection and BOS. But speaking of BOS and chronic rejection, Dr. Alexander, if someone were to come to you with chronic rejection today, what would you recommend?
Thanks, Elle. So yeah, chronic rejection, as we kind of talked about already, we don't have a great treatment for chronic rejection. And what we really work on for CLAD is really trying to work to prevent CLAD from happening in the first place. So what we do in that case is we're trying to target and decrease inflammation for it to occur and also from it to progress. So way that we do this in partially is using certain medications that we benefit from specific properties that they have in addition to their primary uses. So one such medication is, as you mentioned, Elle, azithromycin, which is an antibiotic. But in addition to its antibiotic properties, it's also an anti-inflammatory medication. So we use that, and that's some studies have demonstrated that that may improve lung function after early signs of CLAD have developed. Another medication that we can use is called montelukast, and it's usually used for allergy as an allergy medication, but it can also slow down the loss of lung function. We can also use treatments that target and reduce immune cells, and we often use these medications in acute rejection events. So medications such as alemtuzumab, which really focuses on a type of immune cell called the T cell, or thymocyte globulin, which is a form of antibody as well, which targets these T cells to really deplete them and prevent the immune system from having this really targeted immune response to the lungs. We also have a strategy to target sources of lung injury, such as when someone's having recurrent acid reflux and that acid going back up and into the new lungs that can cause injury over time and also has been found to be associated with CLAD. So there's some surgeries that can help correct this acid reflux and really prevent it from happening. And then there are also therapies that we have that modulate the immune system, such as photophoresis. And so talking a little bit more about photophoresis, what it's called is extracorporeal photophoresis. And what this is, it's a procedure where basically a patient is hooked up to a machine that takes out blood and separates out the immune cells. And then these immune cells are treated with a medication and kind of primed to then be treated with ultraviolet light. The ultraviolet light changes the immune cells. It, in some ways, makes them a little bit less reactive, less aggressive, but in other ways, it's thought to change the properties that make them a little bit more regulatory, a little bit more calming for the immune system. And so you have this nice mix of kind of tempered immune responses and altered immune responses for these immune cells, and then they are put back into the patient, where then some of their effects will occur over time. The problem with this is that this treatment is short-lived. So once these immune cells die off and are replaced with new immune cells, the effect wears off, and so you need to have repeat treatments at regular intervals over time. And what's great about this extracorporeal photophoresis is that there is some data to support improvements in lung function and survival. However, the evidence is not fully clear for the benefit of it, and part of the reason for that is that there's just not a lot of data available. Part of the reason for this is that it's pretty expensive, and the equipment and the services are not available at all centers. And so the main way of access for this, especially in North America, is through research trials. And there are some research trials in process, but unfortunately, all of them have finished enrollment, and so they're still ongoing, but they're not enrolling any new patients at this time. There are also some trials that are occurring in Europe, and so we're waiting to see what these results will be over the next number of years. For future research, we have ongoing efforts to find new treatments. And, as Dr. Turner was mentioning, some of the difficulties with doing research in CLAD is that, one, it's expensive to do this research, partially because there are fewer lung transplant patients compared to other transplant transplanted organs, patients and recipients, and as well as different companies seeing kind of overall benefit for the grander population. So what's a really beneficial strategy is evaluating existing medications that treat similar conditions that may actually help reverse or prevent CLAD in the first place. So one of these medications is called Belumosudil. And what Belumosudil is a type of medicine called a tyrosine kinase inhibitor. It has been approved in the use of reversing or treating what's called bronchiolitis obliterans in patients who have undergone stem cell transplants. And what happens in this case is that these patients develop a response where their newly bone marrow transplants that have been transplanted for them the cells end up fighting their normal organs, and one of the organs that are fought against are the lungs, and this actually develops a very similar condition as CLAD, and so they develop a lot of the obstruction, a lot of the closed off airways that we see in CLAD. And so Belumosudil has been shown to be effective in helping treat patients who develop this condition after their bone marrow transplants. So there are 2 clinical trials currently enrolling patients at centers across the United States to try to use Belumosudil to either treat CLAD at an early stage or to prevent CLAD after having an acute rejection event, which is known to be a known risk factor for developing CLAD in the future. Both of these trials can be found on clinicaltrials.gov. If you just enter the following codes in there, you'll go right to the page that describes the trial, as well as the centers that are potentially enrolling at this time. So with that, I wanted to pass it back over to Elle to kind of talk about, what after her diagnosis with CLAD and going through, the treatment process, what have kind of been the future avenues that have been presented to her, and how is her course going over to this time?
Thank you, Dr. Alexander Graham. And that was very informative on the research on the trial part. I wish I would have known that in 2015. So as I mentioned earlier, my center doesn't do photophoresis. And although I have been in chronic rejection since 2015, my lung function did drop, as I mentioned, about 40%. However, I've been completely stable since being diagnosed with chronic rejection. My lung function has not dropped lower since I was diagnosed. I still live a very active lifestyle. I work full time, I travel, I love to dance, I love to do yoga. I try to stay as fit as possible, which I think has really helped me a lot in building the endurance and building my not reversing the lung function because chronic rejection is not reversible, but in my case at least, but it has kept my lung function at bay and it hasn't declined further. I did, however, decide that I wanted to possibly go ahead and start a new retransplant journey just to see if it's time for me to be listed. So I went to a different center this time just because my original surgeon who did my first lung transplant, he is at another center here in Florida. He's at Mayo Clinic, and I decided to follow him because he has proven to give me great results despite the rejection. So I went ahead and I got evaluated in 2021. I started the 2022. I'm sorry, I started the evaluation for retransplant. It was about a 2-year journey for me with all the testing and having to go back every 6 months because it is a center that's about 6 hours away from me. However, I just got the news recently, a couple of months ago, that it's still too early for me to get transplanted, which was great news to hear because that means that whatever I am doing, despite the chronic rejection, it's working for my kings and I'm doing a great job. And I am nowhere near another retransplant at the moment. Um, I'm still living an active lifestyle. I'm still stable due to the treatment regimen of the azithromycin and the Symbicort inhaler. Um, Throughout the years, that regimen has not changed. I do from time to time catch your cold or get a flu. That's just something that's always going to happen. But even then, right away, I do my treatments for that. per my team's recommendation. So overall, just to say that, if you have CLAD, or if you're diagnosed with CLAD at some point of your transplant journey, there's so many different, it's a case by case, as you've learned here, and it's not as scary as we would think, because there's so many of us that have CLAD and are living very active lifestyles, and we just keep pushing forward. But I also wanted to go ahead and ask, what is the CF Foundation doing now, um, or what's coming ahead, I should say.
Thanks, Elle. It's always so great to hear your updates on sort of your journey, and we're happy that you've gone through that journey and are continuing to have such a great lifestyle. So I'll give a little bit of background on what the CF Foundation has and will be doing in regards to lung transplant. As part of the CF Foundation's commitment to helping people with CF wherever they are in their journey, the foundation established the Lung Transplant Initiative in 2016, which is now transitioned to being the Advanced Lung Disease and Transplant Program. They aim to enhance lung transplant clinical care delivery, increase the understanding of transplant complications, advance new therapies for lung transplant through clinical trials, optimize organ allocation for people with CF, and improve transplant related support for the community. After listening to the community's concerns over the poor outcomes associated with lung transplant and the wide variability between transplant centers' approaches, it was decided something needed to be done. And so the CF Foundation responded to this concern by recruiting an expert team of physicians and other healthcare providers to create the ALD and transplant program. They started with a focus on clinical guideline development and a vision for a biorepository and database to try and better understand the mechanisms leading to chronic rejection, and it grew from there. The foundation has and will continue to make a significant commitment to improving transplant outcomes for people through this initiative. To give you some brief highlights of the Lung Transplant Initiative, launched in 2016, they held a transplant workshop at that point, and as a result, decided to create the CF Lung Transplant Consortium, which I'll be mentioning. This was a highly competitive process, and I will show you the centers that are a part of it. They then moved towards guidelines development. In medicine, physicians and other providers look to the guidelines to help us decide what is standard of care and move forward the needle on research that needs to be completed. And so they started with just simple, these are the people who have CF who should be referred for transplant. They expanded into what is the definition of advanced lung disease and how those people should be monitored and treated. They then turned their eye to post-lung transplant people with CF. How should they be taken care of? And what models should transplant centers be working on in order to collaborate with CF and transplant centers? They then turn their eye to the CF patient registry, which many of you with CF know. Every visit when you come to clinic, we put a little bit of data in, and that's how the CF Foundation is able to report out how well people are doing after starting modulators and all of the advances that have happened. In 2019, they added an advanced lung disease form to go along with the consensus guidelines so that we can track specific data regarding people who have advanced lung disease and making sure that transplant referrals are happening. They then turned their eye to how can we make sure we're getting enough samples, enough data in order to advance the field in terms of research for chronic rejection and other post-transplant issues, and created the CFLTC Biorepository and Registry Study, which was launched in 2020. They had their first patient in 2021, and they hit 1,000 patients last year. Again, the CF Lung Transplant Consortium was created through a competitive application cycle and includes 15 lung transplant centers across the country, including UCLA and Duke, and as well as in Canada. And these centers collaborate, meet frequently, and help the CF Foundation with the Biorepository Registry and helping make sure that all of the issues regarding CF and lung transplant are being addressed. Notably, beyond these centers, the CF Foundation works with many other transplant programs. There are lots of funding opportunities, and they frequently meet with stakeholders at other centers to make sure research is being encouraged, disseminated, and funded. The biorepository and registry, as I mentioned, is hoping to identify predictors of chronic rejection and collecting biospecimens from patients at various components in order to retrospectively research what could be causing people to have chronic rejection. As I mentioned, they reached 1,000 patients in May of last year. They're now over 1,100. They are splitting it about half with CF, half without. So we have specimens from people who don't have CF and had undergone a lung transplant to find CF specific things. They try to match the demographics of people with CF in our country with ensuring that there is adequate ethnicity and race being represented. You can see they've collected a lot of specimens, a lot of data, and they thankfully are connecting this with the CF patient registry, which allows for even more data over such a longitudinal period of time. A few more highlights. Again, they looked at in 2016 expanding just transplant outcomes in general, the advancing research solutions to chronic lung allograft dysfunction applications went out in 2018. And you can see throughout the years, they continue to specifically fund research in large cycles, looking to understand why chronic rejection happens, identify reasons beyond what we know, support young transplant investigators with planning grants to facilitate larger grants through funding mechanisms like the NIH and other investigator-initiated projects through the CF Lung Transplant Consortium. One example that Dr. Graham and I recently worked on looked at the use of a diabetes medicine that had previously been reported in smaller groups to help prevent chronic rejection and looking at that data in data that already existed. And moving forward, they continue to hope to supply more grants regarding chronic rejection, how it is happening, and using available data from other longitudinal studies of lung transplant. Taking one step back, one of the guidelines that was most recently published from the ALD and transplant program creation was in regards to the concern of how do transplant centers and CF centers collaborate after a lung transplant for a person with CF, and created two models, one where a CF center collaborates very closely with the transplant center and takes over the CF components of their care, and another where a transplant center refers out for the specific non-lung transplant components of a CF patient's care. And by defining this, they're helping to learn a little bit more about what is happening for people after a lung transplant when they have CF and how to best take care of them over time. For a person who has had a lung transplant, who has CF, as well as their care teams, the CF Foundation created through the CF Lung Transplant Consortium this wonderful checklist that can be downloaded through the QR code on this slide or from the CF Foundation's website. And this is a great checklist of going through what are the components that make a person with CF potentially different than a normal non-CF post-lung transplant patient, and making sure that every component of their care is being tailored and addressed. This checklist is perfect to bring with you to a visit and highlight to your team if there have been updates that they may have missed, and to keep for yourself to look at every 6 months, every year, to make sure that you're addressing components of your care that could get lost in translation, especially if you're at a CF and transplant center that aren't directly connected. And again, you can use the QR code on this slide or go to the CF Foundation website. Looking to the future, the CF Foundation just finished an application cycle looking to collaborate with CF and lung transplant centers on that models of care guideline statement and find quality improvement projects to help centers collaborate and take better care of people after a lung transplant. And the CF Foundation, through the CF Circles, which is a peer-led group, is hosting a specific CF circle on life post lung transplant, which happens to be next week. So that small group discussion will really help individuals after a lung transplant find peers, ask and answer questions, and really create connections, because we know that every person is a little bit different after a lung transplant. And so hearing from other people can be very helpful. Your voice is your power, and we want to make sure that people with CF have the opportunity to give their voice to research, give their voice to various initiatives that the CF Foundation is putting out. And so this community voice is the virtual program to connect people with CF and their family members to the CF Foundation through various opportunities. After signing up, you get a few invitations each month, totally optional, but a great opportunity if you want to give some of your time to help make sure that people with CF are represented across the country, across different opinions. And the sign up form just takes 2 minutes, I'm told. With that, I would love to bring my colleagues, Dr. Graham, Elle, back to the stage, and we will go through a few questions. We have 20 minutes or more for questions, I believe. And I'll start by asking Dr. Graham one of the questions that we got before the event. How is pulmonary rehab managed before and after a lung transplant?
Yeah, thanks, Grant. So, you know, pulmonary rehab is a really essential component of the transplant process before and after transplant, as this question alludes to. And it's because lung transplantation really takes someone to be in as best strength as they can be, despite being as sick as they are, in order to be able to tolerate the procedure as well as the recovery process after the procedure. So what happens is it really depends on the center. What's common across all centers is that someone needs to do pulmonary rehab, which is a type of exercises for the lungs in a very monitored fashion with professionals that can provide enough oxygen and enough monitoring so it's still safe despite someone having a more advanced lung disease. And so, as I was saying, that common across all of these centers is that there's a pre-transplant pulmonary rehab that has to be completed to get people as conditioned and as strong as possible before their transplant. They end up undergoing their transplant, and then right after their transplant, they start doing rehabilitation within the hospital. And then once they are strong enough, they leave the hospital to do even more work, which is even more outpatient pulmonary rehab to get as strong as possible. So that is common between all centers. How they do it, as I said, is a little bit different. Some centers will have you go to a local pulmonary rehab that's local to where you are, complete that pulmonary rehab before your transplant, and then you come in, get your transplant, and then usually you'll stay at the center that you had the transplant doing their pulmonary rehab program before you are able to get back home and where you normally are situated. Other programs are a little different, and this is how actually Duke operates in that we have you do your local rehab, and then before your transplant, you relocate closer to Duke and you do our pulmonary rehab program as well in order to kind of get as much benefit from pulmonary rehab as physically possible. So you have the best chances as you can for tolerating and recovering after your transplant procedure. And then afterwards, you complete our pulmonary rehab program locally near Duke before you're able to go home. So I think most centers have something similar to that, or they have a permutation of that. Grant, do you have any additions to that?
No, that's we follow the other model where people do pulmonary rehab near their home. Elle, I'm curious, did you do pulmonary rehab before, after, and did you do it after they said you had chronic rejection, which we sometimes do?
Thank you. So yes, I did pulmonary rehab for about 2 months prior to lung transplant, and that really helped maintain my ability to go through the surgery because, as I mentioned earlier, I was only at 17% lung function. I was 92 pounds at the time, barely reaching 92 pounds, and just being able to do my pulmonary rehab with my oxygen. It's not something that they do very strenuous work. They work with you and what your abilities are while you use oxygen, which was extremely helpful for me at the time. But it helped me maintain as strong as possible for transplant, and I think that's why my recovery time was so for me was so easy because the minute I was extubated, they had me up on a chair walk and then walking about a couple of hours later because they really want you to move as quickly as possible if you're able to. And that really, really helped me a lot with the healing process. The minute I got home, right before I got home, actually, I didn't feel comfortable going to a gym, but I did order a treadmill and I would do an hour a day at home. And I'm not as consistent as I should be right now, just because of life and it's a little challenging at times. But I have my Peloton and I still try to get workouts in. You just have to find an exercise that you like and find a routine that works for you. I found that I'm not a morning person, so I will not be up at 5 a.m. to work out. I am an afternoon or evening person when that works perfect for me. So I'll do a class on the Peloton. I have some light weights. I'll do yoga. So those are the type of workouts that I like to do. More, it helps with flexibility and stuff like that, which is also very helpful.
Thanks. I'll remind everyone to please put questions in the Q&A section if you have any.
I
Dr.
think we
why
have
don't I ask-
another question.
Oh, I was
Trying
gonna-
to-
There was a great question, Dr. Graham, about if Belumosudil is administered to every lung transplant patient right away after transplant.
So I think the process. So first off, to answer that off the bat, no. And there's a couple things here. So one is for the Belumosudil, kind of the context that we described it in was in a clinical trial. And so where they would approach that for within the clinical trial would be providing that medication either soon after someone has started developing the early signs of CLAD in order to help try to reverse it, or helping try to prevent it after someone's experienced an acute rejection event, which puts them at higher risk for developing CLAD. And part of the reason for that is that, especially for these medications that are going through clinical trials, you don't want to expose people to unnecessary side effects, as we don't quite understand what the long-term effects of some of these medications can be outside of that context. And so, especially in a clinical trial, you really want to make sure the effect you're seeing is from what you're giving someone. And so that's part of the reason why for that rationale. And also, just from the biology of it right now, it doesn't necessarily make sense yet to start that right after someone has their transplant. But that thought process is really important, because if there is something that we can give someone right off the bat after transplant that helps prevent and kind of primes their immune system or modulates their immune system in such a way to help prevent rejection, chronic rejection from happening, that'd be a perfect agent to have as part of that regimen, including your immunosuppression and your anti-infectious prophylaxis. Dr. Turner, why don't I was going to ask you this next question here from the chat. Is there a CF post-lung transplant registry where data is being actively collected?
That is a great question. Thank you. So it's complicated. The CF patient registry that's managed by the CF Foundation is able to tell when someone goes through a lung transplant and still collects data if the individual returns to their CF program. Then as a CF center, we will put in information about their breathing tests, their complications, their labs, things like that. But that requires them to return to their CF center and be a part of the patient registry, which the majority of individuals are. The alternative is to be at one of the CF lung transplant consortium sites and enroll in the registry that's specifically for that. But that is not everyone that is enrolled in that. And so we do not have every patient who has CF and has had a lung transplant in a registry of sorts. But we are able to extrapolate more data because the United UNOS, the organ sharing information throughout the United States, and the transplant registry collect a little bit of data on why the person had a transplant and some of their long-term outcomes. And so we're able to put together pieces even if people don't return to their CF center. But the most high definition data we have is the CF Foundation patient registry. That was a great question. I would love to now ask Elle, what do you wish you had known before transplant? And what's the most surprising thing afterwards?
I think for me, I was only listed for about 3 weeks. So I didn't really have a lot of time to grasp all the information out there that they have today when it came to transplant. It was basically, I was learning as I went by day or minute by minute, just because every case is different. I wish I would have known more about the effects of the medication and the kidney failure and the risk of kidney failure. Also, CFRD diabetes. So I think that also played a role into my kidney failure along with the medications. So I wish I would have had more knowledge on that. The most What was the second part of it? The most surprising thing about post transplant, I don't mean to sound negative because I've had an amazing post transplant life, but the fact that I'm still here, that has been the biggest surprise. I mean, I'm turning 18 this year in July, so I'm really excited about that. I'm thinking of doing like a party or something to celebrate. And despite the chronic rejection, yeah, I'm still here, still enjoying life. I have chronic rejection, but I don't let that stop me. My life hasn't really changed. I mean, yeah, I get short out of breath, with extraneous activities, but other than that, I'm doing everything that I used to do. A little bummed that, I can't do Machu Picchu, but but there's other places to visit, and I'm fine with that. I see there's a good question here. Is there research on the cost benefit of long term prednisone? Prednisone takes such a toll on the body, and I wonder about its long term use and anti rejection approach.
It's a good question. I can touch on this, Dr. Turner, if you want to answer afterwards, because part of our approaches for immunosuppression after transplant has evolved over time. Transplant has really been something that's been becoming more and more effective over the last 50, 60 years, or 50 years, right? And so prednisone, just thinking about prednisone on its own, is a relatively inexpensive drug. And it's a relatively, in higher doses, is a relatively, it's kind of a kind of non-specific medication in terms of where it has its effect. It's a immunosuppression effect, which is really good at high doses when you're in really high inflammatory states. Right after transplant, right after an acute rejection event, you really want to make the immune system kind of sleep as much as possible. And I think this question really gets at a really important point of that those high doses of prednisone over long periods of time do cause a lot of side effects. It causes impairs the body's natural ability to make steroids because it's kind of suppressing that, and it can also lead to other issues, including bone issues with bone health and diabetes as well. One of the important things I think with the immunosuppression that we do for lung transplant is that we really are trying to use every agent that we have in order to keep the immune system in as great a spot as possible to prevent rejection from happening. And so even though it is a more of a non-specific agent, even just a small amount of prednisone is helpful to kind of keep the whole landscape, the immune system landscape, kind of suppressed just enough to kind of help, especially when shifts happen for the other immunosuppression medications. One of the important things is that right after transplant, people are in really high doses of prednisone, and as time goes on, and this is dependent on the center of how quickly this happens, we actually taper it down to a fairly low dose. Some people will be on 2.5 milligrams every day, and some people will be on 5 milligrams every day, which is still an amount, but it's not quite. It does not have quite the same side effect profile as those higher doses. Um, so I think it's still going to be an important piece of our immunosuppression regimen, partially because it just hits so many different areas. Um, but I think if we had found something that was much more specific for all the little tiny bits that really affect rejection, I think it'd be a really great thing to be replaced by.
Most definitely, those side effects are not fun, And I just want to share that if you do have side effects that you feel are bothersome, talk to your team, see if maybe, depending on your case and your healthcare, if and your regimen, if maybe um, it can be modified or whatever the case may be. I went through an issue with my prednisone where I was extremely agitated to the point where it just was not healthy for me, and they understood and we modified the dose, and my 5 milligrams have been working great for me. So don't be afraid to advocate for yourself.
Definitely. And I think the hardest part about prednisone is that we would love something different. We just haven't found what is better. That we have lots of different targeted approaches, but we as medical professionals still don't fully understand all the pieces of the immune system, despite tons and tons and tons of research in the past and tons to come. Um, there's still a lot to learn. And then the last question we have so far is about azithromycin. And so I'll quickly talk. Azithromycin, as Dr. Graham mentioned, is an antibiotic that's used in a lot of people pre-transplant. And the question is, why is it not routinely prescribed post-transplant as a prevention measure? And some centers do. So every center treats azithromycin, every doctor treats azithromycin a little bit differently. At UCLA, our standard practice is to start it at the time of transplant because that is what we do. And that is what we decided was the way to prevent chronic rejection. But again, not every center feels the same way about that. And so some people will start it if there's an episode of acute rejection. Some people will start it if chronic rejection has started. And we, as a transplant society, realize that that is an issue, that we're using it differently and in different ways for different people. And so, with actually the CF Lung Transplant Consortium, the CF Foundation's help, we have gone to the NIH with a grant to look at this and are waiting to see if the NIH will fund a trial to actually see when should we start azithromycin. So that is to come.
One of the things I want to add on this as well is because, as Dr. Turner mentioned, it all really depends. Different sites will start azithromycin at different times. Um, Depending on the site and the location where that site is, may also influence when someone is started on azithromycin. So, in different areas of the United States, there is increased prevalence of a type of bacteria that are part of the family, the Mycobacterium family, which can be pretty not necessarily aggressive in some cases, but they're pretty tenacious and they kind of colonize lungs and they can cause injury over time. Um, and so certain areas in the United States will have higher prevalences of those in the soil. And so unfortunately, azithromycin partially treats them, but does not fully treat it. So it can spur resistance in those for those bacteria. So in places where someone's at higher risk, just based off of the environment of potentially being colonized or being infected with these kinds of bacteria, a lot of the centers will not start azithromycin until they've started seeing CLAD, just to avoid that risk.
Thanks for that nuance. Sometimes I forget there's places outside of California.
Yeah.
And then I see one more question. Thank you. As a caregiver, how do you use the transplant care checklist? So I think as a caregiver, you can use it just like a patient, downloading it, looking at the various pieces that each individual should have gone through based on their age, based on post-transplant complications, and bringing that with your person that you are a caregiver for to clinic visits, reaching out to your CF and transplant teams in between visits to make sure that all the check boxes are answered. And if they're not checked, why they aren't. So I encourage everyone to download this checklist. It was very thoughtfully created out of the CF Lung Transplant Consortium and hopefully will be really beneficial. Thank you for all of those wonderful questions. So think with that, I'll go ahead and close. Thank you again, everyone, for your participation and great questions. Before you go, please fill out the satisfaction poll, which is under the poll tab on the right-hand side of your screen, right next to this session chat. There are many wonderful resources related to this discussion, including the slides from today in the resource document found on the reception page. Please spend some time exploring the resources, downloading anything you may want to keep, and going to the foundation website as well to find all of those wonderful resources that we discussed. Thank you so much, Elle, Dr. Graham. We're so happy to have had this time to talk about transplant with y'all.
Thank you, everyone. Thank you, Dr. Graham. Thank you, Dr. Turner.
Thanks, everyone. Thanks, Elle. Thanks, Dr. Turner.